Hello and welcome. So today we are going to discuss high yield nephrology. You don't necessarily have to watch the video. You can just close your eyes and listen to this broadcast, as studies have proven that listening with your eyes closed can increase the memory retention. So you have seen a patient with gradually increasing creatinine and you are suspicious of acute renal failure. So to diagnose him, you have to understand some basic causes of AKI. The causes can be broken down into pre-renal, intrinsic, and post-renal. I want you to remember that pre-renal AKI is just a synonym for shock. So any type of shock could potentially lead to AKI. Consider pre-renal AKI when you see a patient who is hypotensive or in sepsis and his creatinine is rising. The basic and evidence-based treatment is simply fluids and in some cases vasopressors. Let's divert a bit as I want you to understand an important fact. So we all know that the best possible treatment of hypovolemic shock is fluids initially and then the pressors. But do remember that in some types of shock, mainly distributive shock, it's best to start with vasopressors, then fluids. You can check that by raising the leg of the patient and measuring his BP. If the blood pressure is increased by at least 10, then fluids are the best option. But if upon raising the leg there is no change in blood pressure, then it's better to start with vasopressors. Let's get back to our topic and discuss some intrinsic causes of AKI. It can be hard to remember all the intrinsic causes, but you can remember them by simply recalling the passage of blood and fluids through the kidney. So the blood initially gets filtered in the Bowman's capsule through glomerular capillaries, and the filtered fluid passes through tubules and finally the collecting duct. So anything that damages these structures can lead to AKI. The immune complex diseases or some vascular diseases can cause obstruction in glomerular capillaries leading to AKI. Among these, the most important is acute nephritic syndrome, that is rapidly progressive glomerulonephritis. Post-streptococcal glomerulonephritis is the most common cause of rapidly progressive glomerulonephritis. Classic case would be a young patient with a history of strep throat who presents within a week or two with rising creatinine. As this is just an obstruction, so the patient would be in fluid overload and you can understand he would be hypertensive. Additionally, the obstruction in the glomeruli can lead to hematuria, micro or macro, and red cell casts in the urine. So the patient fits exactly into the criteria of nephritic syndrome. Some vascular causes can also damage glomeruli, mainly hepatorenal syndromes like good posture or Wagner's. Just remember, whenever you're expecting these conditions, always think of organ involvement besides kidneys, so a patient could present with an AKI and hemoptysis. It's time to discuss the tubules and probably the most high-yield topics. These include acute interstitial nephritis and acute tubular necrosis. Acute interstitial nephritis. Consider this as a form of allergic reaction, notably for some drugs, including sulfa drugs, NSAIDs, and penicillins. A patient presents with gradually increasing creatinine after treatment of UTI with trimethoprim sulfamethoxazole. And surprisingly, his eosinophil count is raised, and there are some eosinophil casts in the urine. Clear your mind and think of interstitial nephritis, and manage the patient simply by stopping the offending agent. I think it's time for the most important and interesting topic, ATN. Let me break down your basic concept of AKI. We know that in AKI, patient is not peeing, but ATN has actually two types, oliguric and polyuric AKI. The first one is mostly caused by trauma or contrast. Consider this: a patient has suffered a hemorrhagic shock and is bleeding profusely. the kidneys are obviously going to sense this hypovolemia and go into pre-renal AKI. As the kidney's perfusion is compromised in later stages, there is marked ischemia of the kidneys, and the tubular cells start dying. This is ATN. Whenever you think about trauma, please consider rhabdomyolysis as your differential. It's a high-yield topic and often comes in exam. Consider a significant trauma that caused muscle breakdown and increased myoglobin. This myoglobin builds up in the tubules and causes obstruction and ultimately leads to ischemia and ATN. How are we going to diagnose rhabdo? You probably are thinking, okay, the myoglobin is the main culprit, so let's catch it in the urine. But myoglobin is not a reliable and sensitive marker for rhabdo. The reason behind that is myoglobin is also increased in MI, and also there is significant obstruction in kidney tubules, so we don't usually see myoglobin in urine. The main marker of rhabdo is creatinine kinase. Whenever there is muscle breakdown, CK is raised. Let me discuss a short case with you. A patient comes to the ED after a motorbike accident. His leg is swollen and you have confidently diagnosed compartment syndrome. A day later, his creatinine jumped from 1 milligram to 10, and now your patient is in AKI. We have performed urinalysis and there are no cells in the urine, and his blood report shows significantly raised CK. This is classic rhabdo. A fascinating fact about rhabdo is the creatinine rises rapidly. So for example, on day 1, the creatinine, let's say 1.5, and on the next day, it is 10 milligram. The basic science behind that is CK gets metabolized into creatinine, and there is rapidly increased creatinine in the blood. So rhabdo, number 1, trauma. 2, raised CK. 3, no cells in the urine. 4, rapid increase in creatinine. Also remember, vigorous exercise and some illicit drugs like cocaine and meth can also cause rhabdo. The next important cause of ATN is contrast-induced AKI. Let's consider an older patient with squamous cell carcinoma of lungs. A contrast CT was planned, and after the study, his creatinine is increasing. What happened is, contrast has damaged his tubules and caused ATN. Older patients are particularly susceptible to contrast, and the best thing is to avoid the contrast whenever possible. Like we can diagnose appendicitis or diverticulitis without contrast, but in some cases, contrast is necessary, like aortic dissection. We cannot diagnose aortic dissection without contrast, right? So what we can do is pump the patient with 1 liter IV fluid and use low osmolar contrasts. Hydration is the most effective and evidence-based prevention of contrast AKI. Let's back up a little. As I have mentioned, there is polyuric ATN. Basically, in these cases, toxins including aminoglycosides and alcohol can directly damage the tubules and lead to ATN. The last category is postrenal, and simply substitute the term postrenal to obstruction. So any kind of obstruction can potentially cause AKI. But the important thing is obstruction has to be bilateral. So for example, if you pinch one of my ureter, I will not go into AKI unless I have only one kidney. So any bilateral obstruction like bilateral stones, BPH, urethral stones can lead to AKI. Some rare causes of obstruction include retroperitoneal blood loss and fibrosis. Let me give you a quick review in a minute. Prerenal AKI equals shock. Obstruction equals postrenal AKI. Drug history, raised eosinophils, eosinophil casts, AIN, acute interstitial nephritis. Trauma, raised CK, rapidly increasing creatinine, and no cells in urine, rhabdomyolysis. Older patients with contrast study give IV fluids before contrast. Young patient with history of strep throat and hematuria, post-streptococcal glomerulonephritis, and finally toxins directly damaging the tubules. So this is all for today, and I'm going to play this stream in loop, so if anyone couldn't join us from the start can benefit from this. And before going off, I would like all of you to pray for the victims of horrific incident in Murray. Thank you.